today's topic is the clinical utility of ATLG as an induction agent in kidney transplant. We all have been using, induction agents since ages, from the time we have started doing transplant. So this is a comparatively new molecule, but still, many people have been using it. So I'm here to provide you a detailed picture of, the utility, the dosages, and the current scenario, the real-world experience of using Graflon or ATLG. So today I'll be briefly touching on the need for induction agents and the trend of usage, mechanism of action, and the type of agents which are available right now. And more importance will go to the the studies which have been published recently over the past 5 to 8 years, which have mentioned about which have detailedly examined the usages and the side effects of ATLG and comparing it with ATG and Simulec and low risk transplant, high risk transplant, and ABO incompatible transplant, etc. So coming to the topic, we all know there is no doubt at all that we nephrologists can't survive without an induction agent. Actually, there are few centers which do transplants without much of induction agents, but still, from the time I did my DM or that time onwards, I have been using regularly induction therapy, and still I don't have the confidence to proceed or go ahead with the transplant. However however good the immunological sites are, but I really don't have a guts to go ahead without an induction agent. So the risk of acute rejection is maximum in the initial weeks to months. Herein lies the need for a strong initial immunosuppressant to deplete or modulate T-cell response at the time of antigen presentation. Induction therapy can mean any agent used perioperatively, but it is now synonymous with the use of antibodies.
Please request the other. Yeah, thank you so much. Please mute the mic.
Yes, sir.
It is now synonymous with the use of antibodies against various components of the immune system. Multiple trials show that induction agents either prevent or delay the development of acute rejection. So, the primary response, the primary immunity is much easier to suppress than the secondary immunity. We all know that. So even before the the antigen is exposed, we can actually, with the help of induction agents, we can actually suppress the immunity so that it will be much easy for the graft to set in actually. So what all types of induction agents do we have? We have basically depleting antibodies or non-depleting antibodies, or we have monoclonal or polyclonal antibodies. We all know the molecules. We have the initial ones, which is like anti-CD3 antibody, muromonabab. Later on, equine ATG has come up, later on replaced by rabbit ATG, which is 2 types, thymoglobulin ATG as well as Graflon. Then we have monoclonals like basiliximab, rituximab, daclizumab, etc. So we will be more concentrating towards the rabbit ATG thymoglobulin as well as the Graflon, which is more prevalent nowadays. So coming to the next slide, like I said earlier, the usage, the trend of induction agent usage in solid organ transplantation, we can clearly see there is an increasing trend of using T-cell depleting agents like ATG as well as ATLG. There are people still, depending on IL-2 receptor antibodies like, basiliximab, and very few people are depending on the proceeding with no induction agent transplants. So this is the current scenario. Over past few years, there is an increasing trend in usage of T-cell depleting agent in the kidney transplant. And coming to the mechanism of action briefly, so it is basically depleting the T-cells. So there are many receptors over the T-cells, CD4 cells and CD8 cells, which will be depleted by the usage of ATG as well as ATLG by apoptosis and other mechanisms. Thymoglobulin includes antibodies against T-cell markers such as CD2, CD3, CD4, CD8, CD11A, CD18, CD25, CD44, CD45, HLA-DR, HLA class 1 heavy chains, and beta-2 microglobulins. Whereas ATLG mainly has antibodies against CD28, CD29, CD45, CD49, CD98, and CD147 receptors with greater selectivity for the cell activated T cells. So the main point is like ATLG has got a greater selectivity for the activated T cells. The mechanism by which thymoglobulin or including the ATLG suppresses the immune response is not fully understood, but includes T cell depletion from the circulation, mainly by apoptosis via activation-induced cell death, antibody-dependent cell-mediated cytotoxicity, and complement-dependent cytotoxicity. Also, modulation of T cell activation, homing, and cytotoxic activities, basically down modulation of the expression of several molecules that control T cell activation, binding to selectins and integrin families, thereby preventing the T cell homing, and prevention of cytotoxic activities. So the slide shows here, like, basically the absolute lymphocyte count before and after the usage of ATLG. I'm here concentrating more on ATLG. So we can clearly see the absolute lymphocyte count has come down significantly after the usage of ATLG. So Graflon mainly depletes CD3, CD4, and CD8 cell, which I mentioned earlier. So here this one absolute lymphocyte count, and here we can see the absolute CD3 counts are depleted, and absolute CD4 counts are depleted, and absolute CD8 cells are also depleted. However, the ratio CD4 to CD8 ratio is well maintained by the usage of ATLG, whereas it is not maintained well in ATG. So there is a selective depletion of cells in ATLG, and the CD4 and CD8 cells ratio is well maintained, and that supports the rationale for lower infection rates and better immune reconstitution compared to ATG. So what is the difference between ATG and ATLG, or are they both same? So it's just like, comparing apple to orange. Both are entirely different. Basically, it's from, the way they are made as the major difference in them. So while both ATG and ATLG are cell-depleting agents used in transplantation, the fundamental difference is their production leads to a distinct immune response and safety profile. The key difference between ATG and ATLG is the source of T cells used to produce the antibodies. ATG is made by immunizing rabbits with human thymocytes, cells of the thymus line, while ATLG is produced by immunizing rabbits with a human Jurkat T cell line. So Jurkat T cell line is like, it is obtained from a leukemia patient, where that cells have been immortalized and been using for repeated studies regarding the induction agents as well as malignancies and medications related to that. So it has been produced by immunizing the rabbits with human Jurkat T cell line. The difference in antigen recognition leads to variations in the immunosuppressive effects and potential side effects such as higher risk of viral infection with ATG compared to ATLG. Coming to ATG, like I mentioned, rabbits are immunized with human thymocytes, and we are obtained the ATG. Antigen spectrum has a broader recognition of spectrum of T cells antigen due to its source from the thymocyte. Clinical use, we all know, of solid organ transplantation, hematopoietic stem cell transplantation, and to prevent graft versus host disease. Potential risk, we all know, like the major side effects which we face is like repeated episodes of infections, including cytomegalovirus infection, and certain malignancies, and severe sepsis, which leads to death or graft loss, etc. Whereas ATLG, like I mentioned, Jurkat cells are the cell lines, recognize a more specific range of T cell antigen. Clinical use is the same, and potential benefit shows comparable efficacy to ATG, but with a lower risk of viral infection, like whatever we have mentioned earlier. And it may also lead to a quicker recovery of the lymphocytes after transplantation, which we'll come to the details later. So this is the gist of whatever I mentioned right now. Graflon and thymoglobulin are produced differently, and we know the cell line. So coming to this slide, so here, like I mentioned earlier, Graflon is less immune depleting than the thymoglobulin at usual doses, preserving the core immune system. So here it is being clearly depicted that the normal lymphocytes are left alone by the Graflon, whereas the activated lymphocytes are more attacked. Whereas in coming to the thymoglobulin, both the normal as well as the activated lymphocytes are being depleted. And concentration, ATG contains 522 microgram per milligram of antibodies, whereas ATLG contains only 160 microgram per milligram of antibodies. So 1 milligram of ATG contains 3 times more antibodies than 1 milligram of ATLG. So that clearly shows ATG is more potent and can cause more side effects also. A dose difference, antibody concentration we already mentioned. Potency, the typical dose used is ATG is 3 to 6 milligram per kg, whereas Graflon is 6 to 8 or 6 to 9 milligram per kg, whereas in Indian real world scenario we use usually 6 milligram per kg. And this is another point which I want to highlight. Graflon, like I mentioned earlier, it's an immortalized cell line, so there is a controlled standardized source is there. Whereas thymoglobulin produced from human thymocytes is donor dependent and variable batches are there. So the consistency will be assured only in Graflon. Graflon batches are highly reproducible, ensures uniform dosing outcomes, minimizes risk of variability in clinical response. And coming to the posology, mainly about the r-ATLG, it's a hypotonic concentrate solution for infusion with pH of 3.7, and it's never to be injected directly. It has to be diluted in sodium chloride solution. It's in a ratio of 1:7. So 1 ml of Graflon and 6 ml of sodium chloride is the ideal dilution, and it should be given as infusions lasting for almost 4 hours. Higher dilutions will cause particle formation, and any solution which contains particles should not be used. So, Kaushal, can you run the first poll, please? Kaushal? Dr. Kaushal? Yeah.
Yes, sir. Yes, sir.
So, in your experience, this is the first question which I want to ask to the audience. In your experience, Graflon selective T cell depletion leads to fewer infection and better immune recovery compared to ATG. Yeah, 30 seconds, so we can close the poll.
Okay.
Can you share the, yeah. So around 40% have told there is significantly better outcomes with r-ATLG, and about 33% similar outcomes. So, I mean, the majority of people have opined that it's either better or somewhat better outcome. So that's, most of the people think so. And about 20% feel that its outcomes are worse than ATG. So this is exactly a divided opinion we have in this group itself to tell that, you have more opportunity to convince or oppose the motion. So go ahead, Jaiju. We'll have the real data coming in.
Yeah. Can close this window. Yeah. So like our team mentioned already, definitely there is a less incidence of infections compared to for ATG compared with ATLG versus ATG. So coming to the clinical experience of ATLG in Indian data, we have a very solid study done by a few of our friends as well as from Cochin. It's an Indian study which included 11 centers. It was a prospective multicentric observation study. Adult patients who underwent ABO compatible kidney transplant and had received r-ATLG as a part of induction were included in the study. Patients were followed up for 12 months post-transplant. The primary outcome measure was overall survival and death-censored graft survival. The primary safety outcome was assessed by the development of infectious complications such as urinary tract infections and CMV infections and pneumonia and development of graft rejection. Coming to the baseline characteristics, I'll just quickly go through. There were around 359 patients. Almost age was roughly around 42 years. Male sex was predominant. Mean ATLG dose administered was around 6.2, and the cumulative dosage per patient was less than 400. Native kidney disease, almost all sorts of kidney diseases were included. HLA mismatch cases were also included, and a few of HIV positive patients were also included in the study. Coming to the results, graft dysfunction was observed in almost 48 patients over a course of 1 year, and BPAR was around 24, 6.7%. And out of it, acute cellular rejection was around 19 patients, antibody mediated for 4 patients, and ABMR plus ACR for 1 patient. Coming to the survival, patient survival after 12 months was 96.65%. Death censored graft survival was almost 99.4%. And we have a beautiful chart which shows, like, the graft efficacy, the graft function was stayed similar, like, close to normal over the course of the study for almost 12 months. So here again, like, as I mentioned earlier, the death censored graft survival of the study was around 99%, and the patient survival was 98%, which was a wonderful result which I have got by the usage of r-ATLG. So key takeaways from the SOT registry: r-ATLG is associated with 1-year patient and graft survival comparative with published literature from similar cohorts. Similar survival and death censored graft survival was noted. Biopsy proven rejection with the use of r-ATLG remains acceptable compared to previous reports. And we observed a limited incidence of infective and other complications with average mean r-ATLG dose of approximately 6 mg per kg body weight. The rate of infection was 13.6%. r-ATLG at the median optimal dose of 6 mg can be effectively and safely used in Indian patients undergoing kidney transplant. So that was a takeaway from the SOT registry. And this is another study from Sir Gangaram Hospital, Delhi. Again, this is a retrospective observational study of 177 patients who received r-ATLG as an induction agent. It included 23 of ABO incompatible transplant patients also, and this is only 2 patients. And here the death survival rate was 98%. Again, the study duration was for 12 months. Here, one major thing which I want to postulate is like that. Here the cumulative dosage was well below 350 of total dosage of Graflon, and induction with less than 4 mg per kg was used for 27. The standard 4 to 8 for 134 patients, and more than 8 mg for 16 patients. And overall, despite this much the usage of r-ATLG, the infection rate was stayed around 22.5%, and the majority was UTI. So here also the real world evidence support the safe and effective use of r-ATLG as an induction agent with an individualized dosing approach. This is again another real world experience from the Fortis Institute in Delhi. Here the number of patients, 54 patients were studied, and Graflon average dose of 6 mg per kg. And here also we had an acceptable efficacy and safety profile in renal transplantation compared with the other studies. And here also the major infection episodes were only UTI, no other major infections like CMV or BK virus, nothing was significant about the noted. Here again, one more study by Dr. Shailendra Tiwari and et al. Here, the number of patients were very less, 35 patients in one r-ATLG as well as 35 patients in r-ATLG group. Similar efficacy has been noted in both studies. Here, the complications, the infection complications included acute gastroenteritis. More importance should be given to the microbiologic isolates, where the Klebsiella pneumoniae infections, E. coli, Acinetobacter, Citrobacter infections were all comparably less towards the r-ATLG side. Tuberculosis, 2 patients in r-ATLG side were